cholesterol is essential. So we can't live without it. The basic function of not only cholesterol, but lipoprotein, which is a molecule that contains cholesterol, fat-soluble vitamins and nutrients and other factors. Lipoprotein serves as a boat to transport nutrients around the body. It's not good or bad, it just is. You just can't live without it. And so going back 150, 200 years when they saw these cholesterol streaks in the blood vessel wall, they said it must be cholesterol as a disease. And as you said, now what we're understanding is it's really a symptom of everything else that's going on. In other words, inflammation, oxidative stress, or causes damage to the blood vessel wall. Now, it can be diet, it can be sedentary lifestyle, it can be smoking. There's a lot of factors that end up causing damage to the blood vessel wall. And lipoprotein and cholesterol is actually there to repair the damage. So if it wasn't there, you'd get into trouble. So in a sense, lipoprotein and cholesterol for atherosclerosis can be a good thing, trying to repair the damage.
Friends, we're here live with Dr. Jeffry Gerber, family physician here in Highlands Ranch, Colorado. We're going to kind of debunk some of the myths surrounding elevated or the correlations between cholesterol and heart disease and really kind of introduce a novel, not really a novel concept, something that you've been measuring for quite a while, Dr. Gerber, over 2,000 two-hour glucose tolerance tests. So we have a lot of data, and we're going to talk about insulin and heart disease and much more. So first of all, thanks for coming on the show. I really appreciate it.
Yeah, thanks for having me, Mike. You told me that you used to live in Colorado.
I did.
We met a couple years ago.
Yeah, in your other office, I think, down the way here.
Yeah, well, really, it's great to have you again. And
thank you.
We were talking before that I'm a family doctor, traditionally trained, but I've been focusing on nutrition, lifestyle, and functional issues for the past 17 years. And it starts back in about the year 2000 when I started reading about nutrition. It was specifically Atkins diet. And I had some challenges from my family because I had some weight issues and some personal health issues. And I lost 40 pounds right away, which was just amazing. And then I started to research and do my own homework to understand what exactly was going on, and realizing that metabolic disease really defines a lot of the chronic diseases that we see every day in modern medicine. And so from that point forward, I've been really trying to bridge the gap with my patients, applying principles of modern medicine, but also looking at nutrition, diet, lifestyle, and functional issues, and to realize that that's where the root causes are. And with the health insurance bubble about to burst, I don't care who's in office, we have a problem with healthcare. It's becoming more expensive, and people basically are, wanting to give people access to it, but limiting the services you get. And the idea is, why don't we just address the root causes so that people don't get sick in the first place?
Right.
Makes sense.
Absolutely. And treating one of the root causes, that you've been speaking about and educating your patients and practitioners about is this metabolic dysregulation and hyperinsulinemia, and how that's kind of a root cause driving other aberrations, if you will, abnormalities within the body, like elevated cholesterol, triglycerides, and so forth. So let's kind of talk about the role that insulin plays in heart disease progression and atherosclerosis.
Yeah, so in general, this whole idea that we're now dealing with metabolic disease that is, it's related to insulin, hormonal dysregulation, leading to things such as inflammation, oxidative stress, and advanced glycation. And it changes our whole approach to nutrition. Our nutritional approach goes back almost a half a century. Over 50 years, we have simply focused on reducing calories, reducing fat in the diet, and to lower cholesterol. And that just misses the mark in so many ways, that healthy people simply need to have low cholesterol. And it doesn't address hormonal dysregulation, and it doesn't address insulin. And so the idea is that in our office, we became aware of something called the metabolic syndrome that was coined by Jerry Reven back in the 1980s. And he connected so many of the chronic diseases to hormonal dysregulation, and the metabolic syndrome. We've actually done, as you mentioned, over 2,000 glucose challenges in the last 17 years, and we're going strong. And in recent years, we started measuring not only fasting insulin, but the 2-hour insulin.
Wow.
And this is based on the work of Dr. Joseph Kraft, who spent a career over the last 4 decades studying insulin metabolism. And he noted that there was a strong relationship between hyperinsulinemia and heart disease. And his point is that there are patients that have heart disease and they don't know that they're diabetic or they have hyperinsulinemia. And what we also see in our office is that there are patients that are diabetic and they don't even know that they have heart disease. And there's this big disconnect, and it's really what we were trained in medical school, that diabetes and heart disease are almost 2 separate entities.
Right.
Now look, the cardiology guidelines, the 2013 American Heart Association guidelines, do talk about diabetes as being one of the, they call it a cardiac risk equivalent, but the way that the calculators work, diabetes is buried in the calculators. And they're not measuring glucose. They're not measuring hemoglobin A1C properly. They're not doing glucose challenges, and they're not even measuring insulin at all. And so what we're finding when you start to peruse through the data, you can see that there's a very strong association at this point between diabetes and heart disease, almost more so than lipids.
Right.
Yeah.
So basically, to kind of summarize what you're saying there, so the traditional cardiologists and traditional doctors are looking at things like CT scans and coronary calcium scores and stress tests and saying, okay, your risk is high or low or whatever, but they're ignoring the metabolic component, sort of.
Well, let me qualify that
Sure.
a little bit. I would say, what mainstream is doing is simply just looking at cholesterol. And the cardiologists, what they do is the imaging that they're doing are the heart catheterizations, and they're just looking at if the artery's clogged or not. And I mean, that's not a bad test, but it doesn't really address prevention. The cardiologists, they're looking at it after you had a heart attack, or the pipes are clogging at this point. It's already too late. And so there's other imaging that can be used for preventive purposes, and that's imaging such as the CT of the heart, which is the calcium score, or even you can do ultrasounds to look for early plaque. But the calcium score is particularly interesting because the amount of calcium correlates with risk, and it's a magnitude of order difference compared to looking at the risk calculators,
right,
and looking at cholesterol. So that's actually a really valuable tool. And the cardiologists, they're not addressing, again, atherosclerosis as a metabolic disease. And that's what we're trying to do.
Right.
And we do that every day, and we approach it through proper diet. It brings us back to diet. It doesn't bring us back to expensive procedures, medication, lipid lowering, medication for diabetes. It's simply diet. And so the problem is, how can you make money in the healthcare industry if you're just going to tell people how to eat and live better?
Right. It becomes challenging, right? I mean, unless you own the patent on avocados, which no one really does.
Let's do that.
Yeah, let's join ventures there. But what's interesting, so the traditional model is about cholesterol lowering, but that doesn't address the core metabolic dysregulation that's causing all this heart disease factor. So let's kind of talk about this metabolic dysregulation. I think kind of wind back a little bit to the glucose tolerance test that you've run over 2,000 of. What is that exactly? And then why did you add insulin into the mix? And then how does one go about ordering one of these if they want to assess themselves?
So we think that doing a glucose challenge is a great screening tool for the general public. So if you're already doing a low carb diet or a ketogenic diet, it actually interferes with the test. You can carbohydrate load for a week or two before the test. That's 150 grams a day for 7 days. But why would you want to do that if you're already low carb or ketogenic? So people coming in off the street, they have general health issues. So they're concerned about cardiovascular risk. Glucose tolerance test. That's the first thing that they need to get done. Okay, they're worried about diabetes. Do a glucose tolerance test. They're worried about their weight. Do a glucose tolerance test. They're worried about chronic inflammation, arthritis, premature aging. Do a glucose challenge. Again, Dr. Kraft demonstrated that at least 2/3 of the population have a problem of hyperinsulinemia. So there's so many reasons to do it. So you come in fasting. In our office, you drink 75 grams of a glucose solution, and we have you sit in the waiting room, and we monitor you for 2 hours, and then we meet at the end of the visit. And so we do a fasting insulin glucose, we do a 1 hour glucose, and then we do a 2 hour glucose and insulin. So it's a short Dr. Kraft version. So he did the 5 hour glucose challenge with insulin, and he was measuring at the beginning and then at half an hour intervals. And so practically speaking, it's hard to do. So some people say, for instance, Ted Naiman says, well, why would you have anybody drink that terrible sugar solution? Well, again, it's a baseline of people that have health concerns, and it gives us a really good understanding as to what's going on. So for instance, I had mentioned we had a patient this morning. So if I recall, the person wasn't at ideal body weight and wanted some nutritional advice. So we did a glucose challenge. And what might seem surprising to you, but not to me, is that fasting parameters were normal. During the glucose challenge, both the fasting, the 1 hour and the 2 hour glucose were in the normal range. Okay, I can't remember the specific numbers, but fasting was under 95. The 1 hour glucose was under 155. The 2 hour was under 140. And we get the 2 hour insulin back, and again, normal is less than 30. So his 2 hour insulin was 160.
Oh my goodness.
I mean, we've seen much higher, but so if you don't test the parameter, you're not going to know there's a problem. So he clearly has an issue of hyperinsulinemia that would be best approached with a whole foods diet where you're cutting out sugar, grain, starch, and the industrial vegetable oils, canola, corn, soy, which, by the way, are very atherogenic, inflammatory. And so this is the value of the glucose challenge. And I think that more healthcare professionals should be doing the test, or at least thinking about hormonal dysregulation in this way. Unfortunately, like I said previously, we're not trained to think about heart disease and diabetes in the same breath.
Right. Dr. Gerber, very fascinating. Now, let's kind of, what I'm curious about, did you add on the 2 hour insulin, or is this, is it complicated? From a logistical standpoint, I know on like a LabCorp request, you just check glucose tolerance test, someone goes in and does this. Is there any special, or are you going to get any kickback from adding insulin onto that from insurance companies or anything else?
Insurance doesn't have a problem with it these days. But the healthcare professionals think that it's an inconvenience to them and the patients to have them sit around for 2.5 hours. So we actually do the test here in the office. Now, we're lucky. We have a lab right downstairs.
Awesome. So
we do the finger sticks for the glucose here, and then we run them down for the 2 hour insulin, because we can't measure that, because it's a radio immunoassay technique, and so it's very low concentration. So if we could measure insulin at home, it would be wonderful, but we're not quite there yet. So they go down to the lab, and the information is just invaluable. And again, healthcare professionals, they'll say, well, we'll just measure your hemoglobin A1C and your fasting blood sugar. Now, that can pick up a percentage of the patients. Actually, Dr. Kraft, when you look at his data, and I did, and I actually reanalyzed it, and I'm not that great with spreadsheets, but you can see that just fasting methods only picks up about 30% of the patients that have a problem.
Wow.
Compared to if you did a glucose challenge with Insulin Assay.
Interesting. And that's really because insulin can, it's going to overcompensate if you are insulin resistant, and that's what we're trying to find, is how much someone is overcompensating by how much insulin they're releasing. Yeah,
so what, insulin can compensate for blood sugar. So, you can have hyperinsulinemia with normal blood sugars just because you don't know it. Your insulin's rising and rising, trying to maintain blood sugar, and if that's all you're measuring is the blood sugar, well, you're going to say, oh, you're fine. But you see that you have hyperinsulinemia, which is becoming more and more a problem as the insulin's rising, and this actually precedes insulin resistance. So insulin resistance is something that occurs downstream where the end organs become resistant to the insulin message. And so if even measuring for insulin resistance, that's a late finding too. So the insulin is golden.
Definitely.
Yeah.
A lot of questions come up. The first one, because a lot of people that tune into these videos and podcasts and so forth are keto-adapted to fat-adapted. They're doing low-carb diets. Is there any, in terms of your clinical feedback, would you suggest trying this once a year, every other year? If someone's overall healthy, just wants to get an insight into their insulin resistance, kind of a snapshot of that, if you will, is it worthwhile doing if they're keto-adapted or?
No.
Okay.
I really don't think there's a benefit. The ones that we've done it on, we've basically just been experimenting because there's, as I said, being keto-adapted can interfere with the glucose challenge in a way that we call it physiologic insulin resistance. And it's kind of complicated, but a patient, let's say you come in, you're keto-adapted and you do this glucose challenge, well, you would actually find that your insulin level would be flat throughout the 5-hour insulin assay. Now, your blood sugar can be variable. Now, that could actually be good, but it could also shoot sky high at 2 hours. And opponents to low-carb diets say that this somehow represents some type of insulin deficiency or carbohydrate deficiency in the diet. But what Dr. Kraft showed back in 1975 is actually a normal physiologic adaptation of being on a low-carb diet. Your body doesn't need insulin if you're adapted for this period of time, so you're basically putting it into shock.
Oh, wow. Right. It's like a stress response of sorts.
Yeah, it's a stress response, and the insulin, it'll wake up if you just eat 150 grams for a couple days before the challenge. And then what you would see in someone like you who would do the glucose challenge is that your insulin pattern would return to a more normal level, or perhaps something else if you still had a problem, and blood sugars would level out.
Right.
And so it doesn't really, you don't gain any more information by once a year doing a glucose challenge on keto adaptation. This is where those individuals, you just measure your normal metabolic markers. So you look at your lipids, you look at your fasting blood sugar, you look at your hemoglobin A1C, and then you compare that to last year. You can look at fasting insulin, and to do cardiovascular imaging, perhaps over age 45, and or sooner if there's a family history of heart disease.
Awesome, great info. Yeah. We know from Dr. Dominic D'Agostino, his work, that insulin is a major negative downregulator of the hepatic ketogenesis. So this is really good for people that are having a hard time maybe keto adapting to try and figure out if there is a big issue, you know. So we do hear that. You know, people that are trying to do this, they're like, oh man, I get the keto flu, or I can't keto adapt. And so what's going on with that insulin potentially?
Yeah, well, I mean, the liver's big. I mean, some people argue that insulin resistance is the disease of the liver, and that's where the root problem is. And so, you know, being keto adapted downregulates so many things. In fact, you know, there's some research now from Dominic D'Agostino and Angela Poff. We both met them at the Low Carb USA conference. And its association with cancer. And this Warburg effect that cancer is a metabolic disease.
Yeah, let's dive into that.
And so the idea is that you want to starve the cancer. And there's many ways to starve the cancer. Number one, you cannot eat. Okay, but that's hard to do. You can do a ketogenic diet. They find with the Warburg effect that certain rapidly growing tumors are very sensitive to carbohydrates and glucose, and so you're taking away their predominant fuel. And you can even do exogenous ketones. So what Dom's group has demonstrated in rat models, just fascinating, that using ketogenic diets with ketone supplementation and actually, hyperbaric oxygen, the mice are curing themselves of cancer.
It's really amazing.
Yeah.
Yeah, this whole notion that cancer is a metabolic disease, I think, is really under-recognized in traditional medicine, right? It's all immunotherapy-based and oncologic medicines that focus on the immune system, but we know that the metabolic system kind of precedes these immune dysregulations, which is huge. Yeah,
but so you have to be careful with that.
Yeah.
So Adrienne Schneck is a researcher at the Barrow Institute in Arizona, Scottsdale, actually, and I've come to know her, and she's just fascinating. And she says, Jeff, you can't be recommending ketogenic diets to cancer patients. Now, I have to qualify that. So she's a researcher, and she wants hard evidence in humans to show that there's a benefit. And she has a point. In fact, what she has been involved with is setting up research protocols, looking at diet, ketogenic diets as an adjuvant to standard treatments for brain cancer, which is one that she's particularly interested in. And all we have today are basically case studies, anecdotes, and there are several out there. Andrew Scarborough, I had a chance to interview and meet in London, and he treated his astrocytoma, grade 3 brain astrocytoma, with a highly specialized, actually, ancestral ketogenic diet, along with his doctors, which is really important.
He was working with the practitioners.
They were in support because his traditional therapies weren't working, and we would call that a case control where he's had a lot of benefit. So I actually do see patients with cancer here in the office, and I really have to qualify when they come in, and I say, look, I'm an expert in diet, ketogenic diets. I'll show you how to do a ketogenic diet, but you have to understand what evidence there is and what evidence there is not.
Right.
For benefits in humans. So, you know, the research is ongoing. It's a fascinating topic. Stay tuned.
Yeah, so basically we're at the early stages. We don't know like the cancer subtypes or the phenotypes, and some may be more responsive than others to a ketogenic diet. Is that what you're kind of saying?
The rapidly growing tumors seem to be most responsive, and in particular brain and breast cancer.
Interesting.
Yeah.
Okay, thanks for qualifying that. I think people do get this knee-jerk reaction. Ketogenic diet cures cancer, so I'm going to go on. And so it's nice that we qualify things.
That's dangerous.
Yeah.
I think we really have to understand the science in 2017.
Totally. I love it. Let's kind of switch gears a little bit to cholesterol and talk about insulin's role in cholesterol formation. Not that cholesterol is the end-all, but people are kind of, even my dad, you know, over Christmas, he's like, hey, Mike, can you look at my lab work? My LDL cholesterol is like 127, and my doctor might want to put me on a statin. And so I would love to just kind of talk about kind of the metabolic role of heart disease and kind of that, you know, cholesterol is more of a symptom of metabolic dysregulation.
That's a great way to refer to it. So it is indeed a symptom, and you have to understand that cholesterol is essential. So we can't live without it. The basic function of not only cholesterol, but lipoprotein, which is a molecule that contains cholesterol, fat-soluble vitamins and nutrients and other factors. Lipoprotein serves as a boat to transport nutrients around the body. It's not good or bad. It just is. You just can't live without it. And so again, this going back 150, 200 years when they saw these cholesterol streaks in the blood vessel wall, they said it must be cholesterol as a disease. And as you said, now what we're understanding is it's really a symptom of everything else that's going on. In other words, inflammation, oxidative stress, or causes damage to the blood vessel wall. Now, it can be diet, it can be sedentary lifestyle, it can be smoking. There's a lot of factors that end up causing damage to the blood vessel wall. And lipoprotein and cholesterol is actually there to repair the damage. So if it wasn't there, you'd get into trouble. So in a sense, lipoprotein and cholesterol for atherosclerosis can be a good thing, trying to repair the damage. The problem is if that damage progresses. And so what we're trying to do is stabilize the cholesterol. And so you don't stabilize it by lowering cholesterol. You address the root causes, which is inflammation, oxidative stress. And this is where we start to look at the quality of the cholesterol, that the quality seems to be important. We haven't focused on the quality of cholesterol. What we've been trained as healthcare professionals is to focus only on the quantity. Now look, if you can't make lifestyle modifications, we throw everything we can at our patients. And this actually
as a preventative.
We even give those people medication. I said, look, I can't change anything. So, you know, we want to do what we can. Now, for secondary heart prevention, that is in people that have already had a heart attack, the data presently show that there is still a small benefit prescribing things like statins, if you believe the data. So
more of like an anti-inflammatory, from what I've read, right? I've heard about that. Very interesting.
You took the words out of my mouth. So perhaps it's addressing inflammation, but it's really the quality of the cholesterol that's really, and cholesterol in general, unless you just focus on the the pharmaceutical industry that spent a lot of money to show that statins, you know, have a causal benefit, although small. But we really think of lipoprotein and cholesterol as just, it's an associational marker, okay? You know, you wanna look at disease itself. You get a calcium score. You see the disease in the blood vessel itself. Forget about the cholesterol. Just take a look. Right. And so, you know, it's all associational. Even when you look at the quality of the cholesterol, and the way you look at quality is the ratio of triglyceride HDL. You can now look at the advanced testing, look at the particles, the particle size. Okay, you know, we have others out there that have shifted. Well, you know, LDL cholesterol isn't a good marker, so now we're going to look at the particle count.
Right.
Okay. Now, it is true that the particle count is a better marker compared to LDL. But now they said, well, all that matters is the particle count, which is just like looking at the LDL concentration a long time ago. So forget about quality, we're looking at LDL particles. And we again challenge that. We have a lot of individuals, including myself, that have high LDL particle counts. So mine's in the 1800 range. We have people that are higher, and then you look at the quality. So my ratios look good, my insulin, my inflammatory markers. I have a perfect calcium score of 0. And you know, personally, I've been living this way for over 17 years now. Wow. So you know, knock wood, I will remain happy and healthy and thriving.
That's awesome. So you have a lot of LDL particles in the system, but they're more big and fluffy, not so much atherogenic. Is that kind of what we're saying?
Again, it's associative, but the idea is that we look at these people who have, say, high particle counts, but 90% of them are large particles. So it's a favorable marker. It doesn't mean, you know, you have to just forget everything else. You have to look. You have to really get the big picture in all your patients. You can't look at one thing like LDL particle or LDL-C and say you're healthy or not healthy based on that alone.
Really good tip. And so your poster session that you presented at the Ancestral Health Symposium, you talked about some of these other things like oxidative stress and free radicals, and there were some other, I can't remember exactly, inflammation and so forth. And so these are all kind of components of that metabolic dysregulation. So if you just look in isolation at particle, but not, you know, forget about all those other components, you might just have a kind of blinders on. But because you're eating a lower carbohydrate diet, you have good insulin regulation, you don't have all these other factors, oxidative stress and free radical damage.
If you know, it's simple. In our patients, you do a glucose challenge with insulin, you do some type of cardiovascular imaging as a preventive tool. It's not going to lead to more testing. And the information is powerful. And you can say, you're not okay, you're okay, we need to change diet, you know, and sometimes the advice is still to get people to eat less, believe it or not, because, you know, we actually have patients, women in particular, unfortunately, I'm not picking on them, that I tell them that they're healthy on the inside, but they're not at their ideal body weight. And their cardiovascular imaging looks good. And perhaps they're not at much risk for disease down the road, although, you know, they could have arthritis because of not being at ideal body weight. But I think that my role is to control people's appetite. If you control people's appetite, then they're not going to eat as much. And so there's many ways to do that. So you can get them to eat less. You can force them to eat less, which we know hasn't worked for years, eat less and exercise more. But you can do a low-carb diet. You can do a ketogenic diet. You can compress mealtime. I don't particularly like to call it intermittent fasting, but the idea is once you're keto-adapted, that you're just not as hungry. And so skipping meals becomes just easy to do because you're not hungry. And then this way, you're not forcing people to eat less. They're just eating less because they're not hungry. That gets us away from the cardiovascular bit, but
I would love to. No, that's awesome. That's really good tips. And so you kind of referred to, you know, some of the women. There's this notion of the obesity paradox, where some individuals that are overweight or not at their ideal weight don't really have these complications with heart disease and so forth. And have you thought about that? What do you attribute that to? Inflammation or anything else? I'm just personally curious.
Yeah. So. It's interesting, we don't talk about these people much. And we just say, oh, everyone needs to go on a low-carb, ketogenic diet. And that's just not true.
Yeah.
I mean, we're here in the trenches and we see all kinds of people, and it could be genetic that, you know, they're really good at putting on weight, protecting themselves in times of famine.
Right.
And so, you know, they're not particularly happy because they're not at their ideal body weight. And so the goal is to control appetite and getting them to eat less, and they should, you know, they're metabolically healthy. So that's one thing that's good.
Yeah, it's very interesting. My brother-in-law is an interventional cardiologist, and sometimes he'll have a patient that's like the prototypical, the epitome of heart disease. In his eyes, he looks at the and opens them up, and they're totally normal and really overweight and so forth. And so we have these conversations about what is that differentiating factor, and then paradoxically, a really lean individual that has just occluded and blocked arteries, right? So it's really kind of interesting that the phenotype or the body comp doesn't always give insight.
Right. So there are genetic factors, and genetics is a whole other topic. Again, it's still associational.
Yeah.
When you look at things like ApoE, MTHFR, all these factors that we're now starting to look at, patients come in and the question is, well, what to do if they're the ApoE44 type? You know, are they supposed to, you know, avoid fats from their diet? That's a whole other topic, but we still think that, you know, across the board, a whole foods diet is important. Of course, you know, sugar, processed carbs, the industrial vegetable oils, nobody should be eating those.
Right.
But some people can tolerate, you know, more carbohydrate and protein than others, as long as they're, you know, they're from whole food sources.
So the ApoE44,
not grains.
Yeah.
So,
so those don't necessarily avoid avocados or avoid eggs if you're in that ApoE44 genotype, but play around with it and tinker and test and see what works best for
well,
you.
the ApoE44 is interesting. They say to avoid, you know, animal fats, and you can eat a lot of fish, shellfish, and
nuts and seeds.
Nuts and seeds. I think a little avocado is really, you know, avocado is good for them.
Okay.
It's just the saturated fats, but again, it's associational. When you look at the ApoE44 data, it's looking at the same associational factors like cholesterol. You know, the cholesterol proponents are. Yeah. You know, the goal is to lower cholesterol, and that decreases your heart disease risk. What there really needs to be, and this came up at the AHS conference when we presented the poster, is that we need to take, you know, ApoE44, which, by the way, I'm ApoE22.
Okay.
I'm like highly evolved. ApoE22 came about 80,000 years ago, apparently, and I'm on the other side of the ApoE44. But the idea is that these people should focus on imaging. So the idea is we need studies where we're looking at the ApoE genotypes and imaging over the years. So forget about cholesterol, because the imaging tells us if there's disease or not the cholesterol.
Right,
Yeah.
which reinforces what you've been saying the whole time. Forget about all these associative factors.
Right.
Look at like the heart through
Look
coronary calcium scores. Love that. Okay, a couple questions come up. Advanced cholesterol testing. What tests are you doing? There's Berkeley and Boston and Cleveland and SpectraCell. Have you found any?
I've done them all.
Okay.
And, you know, we started doing them way back. Vaso, I forget who the company was now.
The VAP or something?
Yeah, the VAP was the first one. And so they're actually, they got bought up by Quest, and then Quest bought another one. So they're all good. And so in the years that I've been studying cholesterol and then doing advanced testing, I again have always said and still stand with the benefit of doing standard lipid testing.
Okay.
You do standard lipid testing. It's been around since the 1970s. It's a $30 inexpensive test. We actually do it right here in the office. We can test yours if you want before you leave. Yeah. And you look at the ratios, you look at the history, and I can tell the patient you're going to have large particles. Why do we need to do the advanced testing?
Right.
But even so, some people still insist. Some people have really high LDL, and then we confirm it by looking at the advanced testing, looking at the particle count and the particle size.
Okay. So you've compared, so it's basically, you know, one of my mentors, Gerard Guillory, says, you know, if the test doesn't change your treatment, why do the test? Right. That's the thing. So basically what you're saying is you've done enough of these, you see in the correlations where it makes sense to kind of go and do the expanded test. And so my next kind of follow-up question with that would be, the correlations between high cholesterol and longevity, and paradoxically, 75% of people that have low cholesterol end up with an MI. So let's talk about that disparity there.
Yeah, well, so there was a great study in 2009. I think it was Get With the Guidelines, where they looked at almost 140,000 individuals that were hospitalized with acute events. This was actually all ages.
Okay.
And what they found was 3/4 of them were at goal, but yet there they were in the hospital having a heart attack. So the question is, if they're at goal, why were they having heart attacks? So that's one that challenges this whole cholesterol association. And the second, as you referred to, there was a study last year from Japan looking at large populations of elderly people. And what they found is that the ones with higher cholesterol live longer.
Yeah.
So it's all associative, those studies. So, unfortunately or fortunately, we still have to refer to what's available, but the data that's available. But it just, again, it challenges this whole cholesterol hypothesis.
That's basically what it is. So,
Yeah.
so what that means, really, in your eyes, is really look at the insulin and the other metabolic markers, like the 2-hour glucose tolerance test, and kind of get a look under the hood, if you will, to kind of see what's going on metabolically.
And get your patients jazzed about nutrition and prevention.
Yeah.
And to tell them that they really can make a difference. Because, if your health care professional has given up on you, then, what's the motivation? I think of myself as, a personal health coach for my patients, each and every one. And so, we still deal with, modern medicine. Modern medicine is wonderful. It's life-saving. But when it comes to prevention, it doesn't do such a good job. And so we need to incorporate that and really get our patients to embrace that, to realize that they can make change.
Awesome. Final question for you, Dr. Gerber. There's this kind of notion that when you eat fat in your diet, your cholesterol is going to rise, your triglycerides are going to rise. And we see there's some individuality here when some people are prone to having higher cholesterol with a high-fat diet and so forth. What have you seen when people want to minimize the risk for heart disease and diabetes and they go on a ketogenic diet? Do you tend to see cholesterol levels shift in a positive?
Well, it's variable.
Yeah.
We do see the ratios improve. So HDL almost invariably goes up, triglycerides go down. We see patients that have had triglycerides in the thousands.
Wow.
And they'll come down to the 100 range. Now, they may have some form of familial hypercholesterolemia, but they may not. So ratios tend to improve. The other metabolic markers, the insulin, the A1C, invariably improve. Now, in some patients, perhaps a third, cholesterol goes up, in a third, LDL cholesterol stays the same, and in a third, LDL cholesterol will drop. So for me, my LDL-C, when I was 40 pounds heavier, was the 190 range. And so now that I've been doing a low-carb diet for 17 years, my LDL-C hovers around 160. So I'm one example of LDL dropping.
Right.
So, mainstream isn't concerned about the ones where the LDL drops or the LDL stays the same. They're concerned about the ones where the LDL goes up. And again, you have to look at the individual. You have to look at the metabolic markers. You have to do cardiovascular imaging to see if there's disease or not.
Yeah, really good. All right, so we have some personal questions, 3 kind of more rapid fire, a little bit more relaxed here. So we know that, Dr. Gerber, successful people have a morning routine, some set of, whether it's meditation, yoga, rituals. You have 3 children, I believe?
Yes.
3 children. You've been doing this for over 17 years. You're doing a lot of great work in the world. This awesome Breckenridge low-carb conference that we'll talk about at the end. What do you do in the first couple hours every day?
Yeah, well, number one, thank you for considering me successful. I'm just doing my job.
Awesome.
But, during the work week, I like to not eat breakfast. I think I'm much more clear when I come to work, so I'll have some bulletproof coffee. If I'm hungry, I'll have some eggs. And and I like to be active. That really clears my mind. So I do a more traditional workout when I go to the gym.
Lifting weights,
lifting
style.
More traditional activities like that, resistance training and cardiovascular as well. And I think Darryl Edwards calls it movement, and I think we were designed to move, so I do that. I enjoy skiing, and I enjoy tennis. I enjoy my family. Lately, time to shut off. So the holidays have been really good where I intentionally and purposefully procrastinated.
Nice.
And unfortunately, it's rolling over. So we have this big conference coming up in Breckenridge, Colorado that I've been working very hard to plan. We have 36 presentations.
Nice.
And so just organizing all that has been a task, and
a lot of work.
We have some conferences coming up in Florida later this month, so I have to turn the switch back on.
Yeah.
But time to just unwind is really important.
That's awesome. I wholeheartedly agree with that.
And to be at peace, yes.
Absolutely.
Yeah.
We'll put links below this video for that low carb conference in Breckenridge, which I'm super excited about.
Thank you.
Second question, you're stranded on a desert island. You can only bring one herb, nutrient, botanical, or food substance with you. Vitamin D and omega-3s are covered. What are you going to bring?
Pemmican from Steve Finney.
Nice. Okay.
I think that would help to sustain, and as long as I could hydrate myself, I think I'd do fine.
Love it.
Yeah.
Awesome. And final question, if you're trapped in an elevator with a politician, maybe someone from the World Health Organization, parliament from another country, a president from the US, what are you going to tell them? What lifestyle or health tip would you tell them, and why? It's
true that sugar and starch helps to sustain civilization, but long term it leads to chronic health issues. And if you can look at the disconnect between food consumption and modern day illness over the past 50 years, there's a strong message there that there's something wrong with our food supply.
Love it. Dr. Gerber, thanks so much for coming on the show.
Pleasure.
Really appreciate that. Now, if folks want to learn more about your work and possibly register for the Breckenridge Conference coming up in February, how can they do that?
Yeah, so my website is denversdietdoctor.com. And if you look up on the internet or Facebook, Low Carb Breckenridge 2017, that'll pop up everywhere.
Awesome. Love it. Thanks so much for tuning in, guys. If you like this video, please give it a thumbs up and subscribe, and I'll put the show notes in the description below this. Catch you later.